The topic this morning, as you have seen in the program, is HTA. And I think many of you knows that HTA has two different dimensions. First of all, it is a methodology used for policy analysis and lies somewhere between health economics and clinical epidemiology, which is used to assess the consequences, the implications of the use of medical technologies in terms of economic, social, medical, and ethical terms. At the same time, HTA is also an institutional challenge. You know that several countries decided in recent years to set up a dedicated arm's-length agency entrusted with the task of supporting, from the scientific point of view, decisions of the politicians, for instance, regarding the services to be listed in the benefit basket with universal access, or the technologies to be reimbursed for diagnostics and treatment, like for instance, drugs. You know, in 1999, NICE was established, the National Institute of Clinical Excellence, which is still a reference point in this domain. Just to show these two dimensions, we have during the summer school a course really devoted to the methodology to learn how you do a HTA assessment. At the same time, we have here one of the important figure in the domain. Finn Christensen is the General Secretary of EUNet HTA, which is an organization linking all the agencies working in this domain in Europe. And I hope that Finn will maybe contribute to the discussion later on. So, we will discuss this topic this morning with three experts having very different backgrounds. First of all, I would like to present Burnand, who is also one of the teachers of this summer school. He's a medical doctor specialized in general internal medicine, as well as in prevention and public health. He got an MPH from the Yale University School of Medicine and worked as clinical epidemiologist in the US for the first time. And since 1996, he is the head of the Healthcare Evaluation Unit and Clinical Epidemiology Center at the Institute of Social and Preventive Medicine at the University of Lausanne, University Hospital. He is also the director of the Cochrane Switzerland branch of the Cochrane Collaboration since 2010. He is member of the Swiss Federal Commission for Healthcare Procedures of the Mandatory Health Insurers and founding member of the Guideline International Network. So he will bring much more the scientific perspective on HTA. Then we have Brügger, who is a health economist and the director of the Winterthur Institute of Health Economics at the Zurich University of Applied Sciences in Winterthur. His fields of interest in research and teaching are health technology assessment, patient classification systems, and managed care. He is a board member of the Swiss Network for Health Technology Assessment and Swiss Insurance Medicine, and since July 2013, also of the Swiss Academy of Medical Sciences. He studied at the University of St. Gallen economics and sociology as a PhD in economics, and in the year 2009 he received a Master of Science in HTA. He's more the economist in this part. And finally, we have Peter Suter. He's a medical doctor as well, trained in internal medicine and intensive care medicine in Geneva, San Francisco, Boston, and Pittsburgh. He was for about 20 years chief physician of the Service of Surgical Intensive Care at the University Hospitals of Geneva. He was Dean of the Faculty of Medicine for 8 years. Then from 2004 to 2011, he was President of the Swiss Academy of Medical Sciences and also for 2 years of the Swiss Academies of Arts and Sciences. Actually, he is involved in the Swiss initiatives on highly specialized medicine and on health technology assessment. He has, of course, a scientific background, but also a very strong political experience to see how you organize from the institutional point of view HTA is very well in networking and connecting people.
My very short answer to the question is yes, but. Well, my answer is largely influenced by my position as a public health physician in public institution and also linked with academic. So why this yes but? Yes, we have better knowledge of the effectiveness and potential harm of interventions when we introduce them with HTA. Yes, we have better knowledge about the costs of medical interventions or of a disease, for instance, or at the point where we discuss the introduction of a new technology. The method and practice of health technology assessment have improved over the years, and more people have been trained to this method. Also, the policy makers are more aware of the importance of using HTA, proper HTA evaluation when making decisions, both at the national level, maybe also regional level, and in hospitals or healthcare networks. However, I will now present some of my rationale for my somewhat large but. Well, quite often we pay lip service to HTA. Well, there are excellent HTA agencies in many countries. Well, yes, in several countries it's not so true, and in Switzerland there have been requests for a better support, supported agency for technology assessment in the country. Well, in addition, the system that exists, that is in place in Switzerland as well as in other countries, requests that the assessment is made by the sponsor of a new, possible new intervention, say maybe the drug industry or the device industry, or an association of physicians, a group of specialists that fill all the assessment evaluation following a template proposed by the Federal Office of Public Health. So only the one who are able to do this will be in a position to make an application. So this system might introduce biases in which technologies are examined or proposed and which are not or more difficult. In addition, we still introduce many technologies without proper assessment, proper evaluation, especially when they are not submitted to a formal assessment. For instance, changes in surgical interventions and some low-tech devices maybe that are not fully covered. Given the accelerated pace of the introduction of technology development, well, more information is the information that we have at the time that we make a first decision will be completed in the months and years following this by new information about the effectiveness, maybe in real practice, and about the real costs. And we lack a mechanism of reassessment, re-evaluation. It's under discussion, it's done somewhere at several places, but probably not much. We perform efficacy trial in ideal conditions, very selected patients with ideal teams who are the best to do the performance. Yet, when it's applied in practice, it's with the usual patients, with comorbidities, different ages, and by the usual doctor or the usual teams. So the outcome may be really less favorable, and more serious side effects may appear. Moreover, we have biased publication. Biased reporting of trial outcomes, selective reporting, and all this concur to have an optimistic bias in favor of interventions. We lack comparative effectiveness. We compare the new technology maybe not with the best comparator at the time, and it's difficult when you are looking at the comparison. We really miss information. Well, yes, we have this new network meta-analysis that could help to improve the indirect with indirect comparison, but still it's a methodology that needs improvement. We also lack information from routine practice. What is occurring in the routine practice from routinely collected data for well-designed electronic medical records covering all the healthcare in hospital and ambulatory care. Well, we do have some registries for some technologies, okay, but it's not covering all. Also, data about cost may change, may evolve with once the technology is in place, and we fail to control this. We don't have good system. Finally, we also lack formalization of obsolete evaluation, actually in Switzerland of existing evaluation, but also of obsolete, and this is linked with some confusion at the point of care. I mean, which intervention to keep, which to abandon. Well, of course, there is a natural, history and a natural abandon of obsolete technology, but not always at a proper pace.
Thank you, Luca, for inviting me, and morning to everyone. It's always nice to be back in Lugano, and I would also like to thank you for choosing this topic. I think it's a very important one, and I'm happy to answer this question, and my answer would probably also be yes, but I will answer it in a slightly different way. I would like to start with this figure that you see up here on the slide, and I took it from so-called Cooksey report. It was published in the year 2006, and it was a review on health research funding in the United Kingdom. And what this graph shows is that Cooksey understands HTA as a sort of knowledge translation process. And the whole process starts on the left-hand side, where you have basic research. Then you have prototype discovery and design, preclinical development, early clinical trials, late clinical trials, and then as one piece in the process you have health technology assessment. But that's not the end of this process, it goes on. You have health service research, then knowledge management, and finally the healthcare delivery, the goal of healthcare. And what you see below here is sort of the institutional side in the United Kingdom, all the programs that they have, and also some of the organizations, for instance NICE that was mentioned before. And if you link now this process with the questions that we typically ask in this context, can it work? This is sort of the first part that we can show here. Then the question, does it work, where we move to the real life world, effectiveness, and then the question, is it worth it? Normally that was done in health technology assessment, where you look at cost effectiveness. But the process should not be finished at this point, and very often it is. There's a lack. And we need to ask the question and sort of add one more question, is it used appropriately? Appropriateness of use, I think this is critical. There's overuse, underuse, misuse, all these problems that we have. And if you look at the whole process in a bit of a simplified way, then you sort of have two steps. You start from basic research, and somewhere in the middle, from basic research, there's a transformation into ideas and products. And that's what Cooksey calls the first gap in translation. And if you talk about HTA and all that, this is not the problem we're focusing here. And there seems to be a lot of resources and research devoted to this area. The problem seems to be much more on the second side, where we have this translation from ideas, products, to the clinical practice. There seems to be a clear gap, particularly then in the implementation. And this part of the process needs to be managed. It doesn't happen automatically. The United Kingdom seems to be a bit of a role model in this way, and they try to integrate not only HTA but also other activities in this field into institutional structures. There is this network that coordinates the HTA program that is based in Southampton, the coordinating center, and since 2012 they also try to include health service and delivery research as well as public health research. They have a better integration, and they link it up to the clinical research. If you go one step further and look at the question of transparency and the organizational side, then I think, and probably many of you would agree, that NICE is a role model when it comes to transparency. They have open and transparent processes. You can go to the website, you see what they're doing, everything is published, and they have very good stakeholder involvement process as well. And I think that they're one of the leading HTA agencies in the world, including that. This is always demands in all the countries, but it's very difficult to do. It's also complicated and time consuming, but this adds to transparency. And they're even, I would say, transparent on where they're intransparent. There is something called patient access schemes in cases where they, for pharmaceutical drugs, where they cannot agree on the price at first, so they let the pharmaceutical company behind closed doors negotiate prices with the system, and that is not disclosed, but they disclose that it's not disclosed. So that's sort of another way of transparency. How is the situation in Switzerland if you compare it to the English situation? In Switzerland there was also a review of the HTA process that has been in place since 1996 when the new law came into practice, and it was quite critical. It found a lot of lacks, not systematic enough, not fast enough, and so on, not transparent enough, and one of the problems seems to be that there are not enough resources, so they found that, and it's quite unclear how also the methodology should really put in place in Switzerland. So to sum up, this slide has a lot to do still in this country. So how can we overcome this problem? And I call it assessing the assessment, what is needed. If you have the health technologies and if you have health technology assessment, and I think health technology assessment, what we heard from Luca before, consists of, I call it 3 parts. You can say 2, so you have the methods, and then you have the processes, and you have structures. And all that goes together. And what health technology assessment does is it observes health technologies, it critically observes them. But what is needed is that someone also observes a sort of a second order observation process, what is done in HTA. So we should be as critically with HTA itself as we are with health technology. So we should ask ourselves, is HTA effective and is it cost effective? And there is a clear lack of studies in this field. However, there are some examples. I only list 3, that there are others. One good one, I think. There was a review in Australia on the HTA process that you can download from the internet. They're also very transparent, published in December 2009. And their conclusion was, brief summary, it works, the system, but it can be improved. So they came up with all kinds of suggestions, and they also suggested that after a while, it should be reevaluated how these suggestions have been adopted. So that's one example. Another one is Mike Burnand, who looked at 20 years of health technology assessment, a little paper that he published, and look what have economic relations added to HTA. And his conclusion, he might be somewhat biased there because he's a health economist, but he said economic relations actually have helped to improve the process, to ask different questions, also to probably better negotiate, and also it has improved to generate better data in the whole process, because health technologists, health economists, they want not only surrogate endpoints but also longer term data like quality of life data and so on. And then there is an initiative in Switzerland. We will hear more about it by Peter Suter, the medical board. And the medical board, I think that's a very good idea, that they want to do an evaluation of the impact of their reports that they publish. And we're very proud that we won the contract and we can do this evaluation this year and next year. Then the second question, HTA, is it worth it? I put up a question, we don't know. There's not much studies around. There are a few that looked at this point, but we really don't know. So my conclusion of this first round is that the critical gap is the second gap of translation, and particularly the implementation after we have decided on putting things into the healthcare basket. So then we need to observe how it works. So health service research is key, and implementation research. But this needs to be managed. We need, and particularly in Switzerland, an agenda, a pilot program, resources allocated, otherwise it will not happen, and there must be political will that people want to do. Thank you.
Thank you very much for the invitation to come to Lugano. And as you can see from the first slide, my response is very different. I say, maybe, yes, naturally, this would be the response. Now, I have also quite a lot of ifs or basic conditions, because if we speak about HTA, we can certainly welcome that, be happy with it, but a few important conditions have to be fulfilled. And at least in our country, these questions are always asked, and overall, in a country where we have 26 cantons, 26 different types of cost collections, 26 different types also of cost in hospitals and organizations. Anyway, well, you have to be careful to say where you took your cost evaluation or your cost assessment and so on. The third point was already mentioned. Information must be adequate, and if we speak about the stakeholders who should be informed about that, let's not forget the patient. That the patient knows also something about the value of treatments, maybe also the cost of treatment. Those directly concerned are not only the physicians or the hospitals or the politicians, but some people else too. And the final point, well, sometimes it happens that some results or some work are censored by the pharma company, for instance, who produces this type of treatment, or by the technical developer who produces a fantastic new artificial heart, but he is certainly more interested in what it brings in, or I think most of the times that what it brings to the system and to the patient. Now, on the other side, and I will give you at the end some very personal examples, it has been shown and also been put forward as thesis in Switzerland that it is quite clear that HTA assessment or HTA system brings a clear increase in efficiency in clinical practice. And you see here a few reasons why. Overall, because it may eliminate inefficient treatment. I will come back to that. Finally, it can also bring something by helping thinking in terms of evidence-based treatments, evidence-based medicine, which is not always really taken into account. And the guidelines go with that because HTA can help a lot to improve guidelines. Finally, there are, in the third point here, a few points which have to be considered, were mentioned already for Switzerland. And the second point, for instance, is very important. Switzerland, I will come back to that later on, we have a perfect democracy. The word perfect may be interpreted slightly differently depending on where you are. It's a sort more of a large democracy. Everybody can talk, everybody can block certain decisions by taking a referendum or a simple way to block something. And the inclusion of the stakeholders in this sense, I will also come to that later on, is different in England and in Switzerland. From my poor experience in England, larger experience in Switzerland, because they have a lot of influence in the Swiss system, because it's much more bottom-up than top-down. Good mixture is always the best. Now, I'm coming to the last slide and trying to give you 3 examples in my former different lives why HTA, in my opinion, is important. First, as a physician, as an ICU physician, I need HTA, good clinical studies, to really be sure or to find out what the best option is in a certain situation. And I give you a practical example, more a modern example. Today it finally comes out that the different perfusion liquids we have to treat sepsis or shock sepsis, that's an infectious disease, or mostly infectious disease. And you have always the possibility to give the cheap crystalloids in a CL solution or the more expensive colloid solution. And up to now, the more expensive has much more pharma behind, which means much more publicity and work with the physician in this sense. But the price difference is huge, and the difference in efficiency is zero. Except that with colloids, more expensive, you have much more side effects. It took 20 years to really prove that in a good way. But still today, in 1 month in Lausanne, there is a big symposium on this topic, sponsored by who? I ask you. Naturally, by the right people, and there it's still debated. Also, it is absolutely clear that the cheap solution are much better, less complication, as efficient, no effect on survival, or even a better survival with a cheap solution. You need HTA in the clinical work. Now, in my sort of second life is the academy, where we are pushing guidelines, also with some ethical parts in it, which has to do with complications and costs. I'm very happy to have HTA, which does not have to be done in Switzerland, but it would be good to convince people also in Switzerland. And you see one example here. For certain interventions in a specific condition of the patients, you have the possibility to make a more invasive or a less invasive. It would be very interesting to know the cost exactly of the non-invasive and of the invasive, complication also. And for instance, this will come out tomorrow also in the Yellow Journal of the Swiss Medical Association. It is not always clear that the specialist here, because for this the cardiologist could be the specialist, but as he is the one who is doing the percutaneous, the coronarography, PTCA, he naturally is very interested to keep this. He is interested in that for his activity and for something back here. And the radiologist who is doing the CT is very much interested in that the other one is a better one. But you will see, this time the radiologist won clearly, but you will see somebody saying, no, that's not true what you did, because your cost you calculated only in the region of Zurich. In our region, in Solothurn, it's very different, it's the opposite. That's Switzerland with 26 systems. And finally, the last example from the highly specialized medicine area, proton therapy, as you know, is quite expensive. Cancer treatment, radiotherapy, and the indications which have been proven by HTA to be the good indications are very few, but still, I was yesterday in a meeting where a private hospital says we want to build a proton therapy facility. Costs 350 million Swiss francs. No reason from HTA, from the medical side, to build a new one, because we have one. We have the highest density in Switzerland of the whole world of this proton therapy with 2 or 3 places, that's enough. But again, you have to convince him, and Switzerland is a rich country. It's more difficult to convince people of these things. Thank you.
Thank you very much. I think we can, please to stay here, because we want to reduce the number of shifts. So we start with you for the second round. You have said us that compared with other industrialized countries like the UK, Australia, Canada, or Sweden, HTA is in Switzerland still underdeveloped. However, in recent years we observed some activism also in Switzerland in this field. I have for you 3 questions. First of all, can you explain how the so-called Swiss HTA path to consensus, which is the Swiss way of involving all the stakeholders, really works, and which lessons learned from other countries have been considered in the development of the Swiss consensus model? This is the first question. The second, an important issue, as you told us, in HTA is stakeholder involvement. But of course, this involvement raises the question of how transparency and independency of decision making can be maintained once the industry has an important word to say in the appraisal and assessment. So how far are these aspects taken seriously into account in the Swiss context? And the third question, are there, in your opinion, some aspects in the Helvetic approach that can be considered as useful and particularly innovative, also from the point of view of the international audience or also of developing countries that are maybe starting to set up such a process in their context? So these are very different questions, and they become more difficult because the resource constraint is 10 minutes.
Well, said before, Switzerland is a rich country, and this is, I think, a big handicap to develop HTA rapidly. The liberties for all partners in Switzerland are very big. A hospital can decide to a large extent, not to 100%, what he would like to do. And naturally, the patients have also liberty to choose their physician. And with such a rich country, and also the crisis didn't really touch us, there is no apparent need or very strong need, but a lot of discussion about limiting the increases in healthcare costs, as you know. Now, I'm sorry, this is in German, but this came out in a journal from Basel, coming out on Sunday, normally, which defines what the OECD has found comparing different countries in terms of what Switzerland is really sick of. And you can see here that there is some overuse of medical resources, and if you are a man, you have a much bigger chance to have no prostate anymore at a certain age, which doesn't mean that this was indicated. It was just done because urologist does not have to go through a tumor board in all cases. It is more and more. Well, there is some risk with overtreatment, as you know. And you don't have to read this, I'm sorry, it's in German. Here comes a health economist, it's Felder from Basel, which is quite well known, and he says also clearly in Switzerland we have too many hospitals, we have too many hospitals doing too many things. We have about 5 or 10 times more hospitals than Denmark or Sweden compared to the population. Well, that's part maybe of the quality of the Swiss system. You do not have big differences. However, if it comes to the definition of HTA, what it is, what it should do, for Switzerland the definitions are very similar or identical. Here I took NICE as an example. You know these things very well, that it is not only important to look into this in a medical way, in a scientific way, but also include ethics, law, and so on. And compared to other industrialized countries, naturally in Switzerland, we can learn a lot. And since about 5 years, so different initiatives in Switzerland have a little bit exploded. Here you have two, I will go to in a little bit in more detail. And in the parliament there have been a lot of demands. Now you have to do a HTA agency or institute or whatever in Switzerland. Now what do we have in Switzerland? Very briefly, we have the catalogue of what is admitted of the Swiss Office of Public Health, which is sort of a rapid HTA assessment, and then the HTA initiative. First, this Office of Public Health has a plan, I will come to that in a minute, and then there are two initiatives, one from the pharma industry together with the insurance, for the basic processes, what should be part of the assessment, how should it be done, who should be included, and then below, besides the national level, we have the cantons, which have two initiatives, the Swiss Medical Board, and this is supported by all cantons, by the Swiss Medical Association, by the Academy, and by Liechtenstein. so it's really an international basis, and C's go into complete HTA, or re-evaluation of things which are here, and I will come to that also. Then a little bit borderline, but also go in direction HTA, is an intercantonal agreement for the concentration and coordination of highly specialized medicine. Now, is an integration of these things important? I personally think yes, it's very important. And if you look at the Swiss Medical Board, which started in 2009, it does assessment, appraisal, and decision in the same sort of organization, but separated in different organs. But for instance, decision naturally should also be done or done by the federal office or the political side. Actually, there we are not very strong yet, but for instance, patient information, physician information, hospital information, and political information we can do. Now, this Swiss Medical Board only treats 3 to 4 domains every year, so you have to select these very well. Could they be cost effective if you do something, and is it really a recognized problem? So, this relatively limited number of domains is naturally a problem, but you can do with a certain amount of money, a certain amount of experts, certain things. Now, from the federal side, I mentioned before that the federal office also has some plans, and as normally, if you go, at least in Switzerland, on the federal side, it becomes a little bit more complicated. And this slide is mostly in German, but the complicated scheme is difficult to translate in English because it becomes less complicated. Here's a typical Swiss scheme to make things not too simple and take some time, because you have to evaluate each color, each case, each part. Well, here, as you see, for a clear plan in Switzerland, we are not very far advanced, but you can see about everything, HTA, what the national level is, the cantonal level. You have the HTA up there, the national, the cantonal level, and who should be, what should be in it. Afterwards, the potential application of these HTA national projects are also a little bit complicated, at least for me, but it starts with the right things, with the clinics, also with stakeholders, patients who should be involved. But again, I think our national approach is a little bit too complicated. It took up to 10 years up to now without having anything, and I think it could go on like that. So how could the path of these different initiatives be combined to go slightly in a rapider path forward? I think the common efforts, it's not bad at all, but somebody has to have the lead to push the people, to give them also some deadlines. We have different legal frameworks between the national level, the cantonal level, which play a major part of the health system. We have different promoting agencies and philosophies. The pharma is involved in one basic project. We have this triangle always between private industry, political, academic interests or pushes, and naturally different opinion on practical and theoretical aspects. But we have to have a convergence of that without giving up very important parts of it. First, the scientific basis of how it should be done and what should be implicated. And also a transparent, fair and efficient process. Efficient means also that we are not waiting another 10 years. There are other advantages for going together, naturally better coordination, lower costs, and priority can be better managed. Disadvantages, the cantons actually in Switzerland can go much faster than the whole nation. If one canton starts an initiative, it can go relatively far and fast. The legal basis is not established at this moment, and this is an obstacle which some people take very seriously. Now, what lessons from other countries have we learned? Well, a lot, naturally. But we have tried with the Swiss Medical Board to take the basis of NICE or IQWiC for other questions, and for the theoretical basis, for the assessment phase, this is very good because theory, science is the same for all countries. But afterwards, it may be a little bit different for appraisal, because the so-called social preferences, which means individual preferences, in fact, what do I want from my point of view, from the patients, are different. And we have to take this into account. Another example, when we looked at the the heart problem, we could not take NICE because the technology in England is not exactly the same compared to the technology in CT, computer tomography, than in Switzerland. So we had to take this into account. Now, stakeholder involvement is also different. Stakeholders in Switzerland have a lot to say, and if you involve them early, well, it goes not so fast normally, because we have not a sort of a strong top-down pressure to have some with us. Also, I could imagine that we can do better. Now, aspects in the Swiss HTA approach which can be important or interesting for other countries. I think it's interesting to have a nationwide approach, which is lower, and to give the cantons the initiative, let them develop something, and then take these initiatives when they are a little bit advanced, and take them also on a national level. So using this bottom-up and having a regional approach is quite good. But as you see in the bottom, what I call here absolute democracy is that really at every step everybody can say, oh, never for us, really not the wrong side, or a really only bottom-up approach can be a problem. I think in Switzerland it's one of the problems.
Thank you so much. So, we move a little bit faster in order to stay in time. So I would ask a particular question towards Brügger about a special option that we have in Switzerland, which is called coverage with evidence development. So the question is, what is this coverage with evidence development? What do we know about how it works in Switzerland? And whether this approach could be a promising option also for other countries in the future. So, Urs, for you as well, 10 minutes.
The problem I would like to discuss can be summarized with an often cited quote I took from Martin Buxton. And he once said, "It is always too early to do an HTA until it is suddenly too late." You heard that one. New technologies, they spread a bit like diseases in S-curves. They start at one point and then they disseminate, and if you want to do an HTA, you would like to do it early on, before it had spread out to all to the whole country. However, the problem might be that there is not enough evidence at that point. So, but then on the other hand, if you wait until you have enough evidence, then you might have the problem that it has already spread out the technology to all places, and you might find out that it has limited use or is even harmful. Or if you restrict the reimbursement too early, and you might kill an innovation. So that's the dilemma. And for that reason, a good option could be, instead of saying yes or no in an appraisal committee that makes a recommendation for reimbursement, you could also say yes but. So something in between. And Switzerland has that option since many years for non-drugs, and it's quite a unique case, and I would like to talk a bit about this point later on. First, a few points on this coverage with evidence development. There are different names. that sort of cover the same idea. Some people call it access with evidence development, some people call it managed entry schemes, and there are some other names. There was a group of experts that gathered in a mountain resort in Canada, in Banff, and they discussed what principles should govern this kind of coverage with evidence development. And they came up with 5 points. Is that probably the microphone? The battery, is it? Yes, the battery could be. Can you switch on this one, maybe? Okay, thank you. So you see these 5 points, and I'm not going to read them for you, but behind these points there's some guiding principles or values like transparency, clarity, scientific rigor can be found there, appropriateness, that the coverage with evidence scheme should be developed, that it fits into a particular situation of a country, and of course the last point, it should be independent from vested interest. So this is how it should be. So how is the Swiss situation? Since 1996 we have a new law, and everyone has basic health insurance in this country. And everything is reimbursed, and you find that in the law, these 3 famous points. It needs to be effective, appropriate, and efficient. And what was unique in that law was that it was possible to reimburse something even if there was not enough evidence at a particular point in time. And the system could sort of guarantee temporary coverage for a certain period of time until better evidence was available to take a final decision. So how does the process look like? And before I explain this point, I have to say that unlike pharmaceuticals, where there is a positive list in Switzerland for medical procedures, there is sort of a negative list. So we say that everything that a doctor does is reimbursed because it is believed that it fulfills the criteria until someone has doubts. And if someone has doubts, they can go to the Federal Office of Public Health and say, well, we don't believe that it fulfills the criteria, and then it is checked. And so only the controversial procedures are examined in detail. And for that, the Federal Office prepares the documentation, and then it goes to a commission, and the commission makes a recommendation, and then the health minister decides whether it is reimbursed or not, or whether it is reimbursed on the condition. So they have these 4 options to answer: yes, no, or the 2 in between. Yes, in evaluation, which is the coverage with evidence option, and there was also a 4th option, no in evaluation, that was used until 2004, but it's not used anymore. And the 2 yes on the left side mean that there is reimbursement, the 2 on the right side mean there is no reimbursement. And that's probably the reason why this no in evaluation did not work. So the commission said it's not reimbursed, but there should be further evaluations, but then there was no pressure that could be made on the manufacturer to make it more evaluations because it was not reimbursed, so that didn't work. But the other side actually worked, and then typically it's in this status for 3 to 5 years, then there is a re-evaluation, and then there is a final decision which can be yes, no, or there can be a prolongation of that status, so yes in evaluation will continue. And this decision yes in evaluation can come with other restrictions like keeping the registry or making additional study, or it can be restricted the technology to certain centers, or there can be some other restrictions. And this option has been used quite frequently. So if one knows that only 120 technologies since 1996 have been examined as being controversial, 45 of them were in this regime of yes in evaluation. And I believe that Switzerland is probably one of the countries in the world that has the most experience with this option. However, we do not know how it really works. It has never been evaluated. So this sort of second order observation has not been done on this. it's quite an intransparent process. All we know is the final result of the decision that is published in the procedure ordinance, so in the law, in the annex. We see whether it was yes, no, or we don't know the reason for the decision, or why it was controversial. All that is not published. And you see the different areas. So how was this option used over the time? You see, in 1996 it started with 4 or 5 technologies, and the light grey bar is the initial evaluation period, and some of the technologies had a prolongation of the evaluation period. You see where it happened. And you see how over the years how these technologies how it happens. But if you look at that, what we don't know is if there was a change of practice. There seems to be one. There seems to be the case that more technologies came onto that regime in the first 6 or 8 years, and then there was a change. So there was a slower pass after that. And it would be interesting to find out why this change happened, if there was a reason for that. What we did is we looked at all these annexes of the ordinance procedures every year by year, and we looked how the things changed, and we noted it down for how long it was in that regime and what the final decision was, and we tried to statistically analyze a few of those data that we generated. And here you see a graph that shows the probability of the final decision for a yes or a no over the time. So you can read it like this. At the beginning, so there's no decision for these yes in evaluation cases. And then after some time, some become a yes, a definite yes, that's the blue line, and some become a definite no. And then this gap of 100% of technologies in this regime narrows, and only after 11 years all the cases have been decided. And after around 6 years, roughly 50 to 60% have been decided. So it takes quite some time. So a first conclusion of all that this option, to have this option of coverage with evidence development for medical technologies, and not only for pharmaceutical, where it is not used in Switzerland, interestingly. It's only used here for non-pharmaceuticals. It is an established option. It's, I believe, a good possibility. 80 medical technologies, if you count the yes and no in evaluation, fall under that regime. Average period, I said, is around 5 to 6 years if you calculate the initial and the prolongation period. And there are some registries used, but there's also very little is known about these registries. They're not published, the results are not published. We try to find out how they're financed. You must know someone who tells you behind doors how it's done. But it's very transparent, and we think that's wrong and that should be changed. There's no formal process for evaluating of the evaluations. The thing I said in the first part, we should have that. There's no investigation on funding, so this is unclear. There's also no evaluation of failures. In one case, we found that a registry that is mandatory, or was mandatory for all the technologies, was only used in about 20 to 30% of all the operations that were done in that case. So this shows that it's probably not in every case done properly. So the conclusion of this slide is further research is needed, and I don't want to end with this. I say yes, we will be doing that now, and we just started a new study. You see the name of it, conditional coverage, or coverage of evidence development in health technology assessment, a pattern analysis of decision making for medical procedures within the Swiss statutory health insurance scheme. So what we would like to do now is to examine these cases, these 45. Now it's, I think one more has been added to the list. We want to examine them, look at this data, analyze it statistically, and to learn more about the institutional side of the process. All we can do is to get some insight is to talk to the people who were involved in this commission earlier and who are involved now. So we do some expert interviews, and we try to find out more about this interesting process, which could be also interesting for other countries, because this coverage with evidence development option has been promoted as a promising thing in many countries. However, the experience also in the United States, for instance, where it has been used, is not so promising, to be honest. So we want to learn where are the problems with it, what are the success factors. It should be finished, this part of the study, next year, and it's sponsored by the Burnand Foundation. Thank you.
So, I think to be fair, we should give to Bernard 10 minutes as well. I have the responsibility for not keeping the time, but I think it is important to listen. Also, the last point I would like to discuss, and then we open up the floor. So, in this summer, I took with me to the beach a book of an health economist, Gavin Mooney, who was killed in Tasmania a few months ago. The book is titled Challenging Health Economics, and a sentence was for me very striking. He said that the health economics community has been obsessed with health and in many ways to the neglect of healthcare. In fact, the commodity healthcare has attributes that go beyond health. Having one's dignity respected, one's autonomy protected, or one's shame acknowledged can matter to patients as health gains matter. So, I think there is a need to go beyond quality maximization. I mean, to go beyond just maximizing health. So, the question I would like to ask Bernard are the following. Can HTA be developed beyond qualities? Can we include other dimensions to embrace more than just health? Which conditions are necessary to build an effective citizens' involvement in HTA? And according to your expertise, how can the claim of Mooney to have such institutions of voice, what we have maybe extremely developed in Switzerland, can be embedded in a proper way in the HTA process? So 10 minutes to you as well, Bernard.
Okay, thank you for the challenge of trying to answer these questions. I will start with two general slides and then answer the question. This is a general slide about the knowledge cycle. We start from practice, from questions, we do research, trials, and then we try to do summaries like systematic reviews, health technology assessment, or critical synthesis. And then we try to implement them with tools like following a HTA at a national level, legal decisions, or in hospital organizational decisions, and guidelines, technical pathways. So you can see that there are parallel tracks for this, and as we have seen before, I mean, we develop guidelines, but HTA in guidelines you should also take into account the values and the cost and so on, and we may need less duplication in here. But the methods are not always the same, and the names are not always the same. So it's maybe a question of branding. So enlarging the scope of HTA, for the first point, the place of the healthcare system, well, as you know well, it's an important place now in developed countries, more and more in other middle and even low-income countries. It's an important part of the GDP. It's also an important economic sector, a large workforce. A source of income for the professionals, for the private sector as well, and the development of technologies in healthcare. Well, it's more and more predominantly coming from the private sectors. If you look at the source of fundings of randomized clinical trials, it's increasingly the private sector and decreasingly the public sector in general, and also in Switzerland. And also it's probably more targeting the people who can buy the technologies, you know, and it's more difficult to have interventions for rare diseases or for diseases that are as specific to countries where neither the people nor the government can afford to pay a lot, and we know these biases. So for the last point, the public health approaches, it's one one way in the direction of Muniz. They say, well, maybe we should look at the facts, the global burden of disease or local burden of disease, and look at the facts and try to tackle the things. And I will come back to this question later. So now I will start with the question one. So about how far beyond the qualis and gain maximization should we go? And for this, I think we can look at HTA in a narrow definition or in a broader definition. Of course, if you have looked at the definition before, it's relatively broad. You can evaluate health systems. Well, now when you look at HTA reports in the HTA database at the Center for Reviews and Dissemination at the University of York, there are 12,000 of these reports. Most of them are really narrow, focused on one drug, one device, one screening test. You may find several others on behavioral interventions and rarely more organizational intervention like case management of complex cases, elderly patients at home. Well, yeah, the definition of HTA encompasses, the healthcare system, the organization of the system, but it's more probably, as was said also before, health services research, and that gives some responses to this, or policy analysis. So there may be also a question of branding. We can try to use HTA for evaluating everything. It's also a question of definitions of domains or specialties. Second point, HTA is a reactive process. I mean, most of the time, health technology assessments are done in reaction to the development of a new technology. So the new technology develops by the industry, by the public sector, and in reaction we do technology assessment. At the national level, we look if we can reimburse this, and at the local level, the hospitals say, well, do we have the resource, the finance for this new technology in our place? So going to the reverse, going to the proactive approach from a public health perspective, again from the global and in the country model local burden of disease. It was a huge work that has been done. If you look at the papers that were published in the Lancet in late last year, really huge work to give this. And it may help. So you start from what you see, and you use what you have, the workforce, the infrastructure, and you try to redesign, re-engineering of your system to tackle this question. Well, you have to take your resources, your context into consideration. And in the same vein, I mean, the health promotion, preventive approaches, many of them are effective, at least some of them, but they are really underused. And we will probably not have the time to go into the details. And moreover, the global intersectoral approaches. I mean, if we want to improve health, maybe we have to work, and we do, with the food industry, to have healthier food. Also with the people who are design environments to increase the possibility to have more physical activity. And also with the environment, to increase the risk linked with the environment. So it's really a global issue for health. Well, when evaluating such approaches, we can still use the techniques that are used by health technology assessment. Again, they are used with other names, and it's a larger policy. Again, it's a question maybe of branding and of techniques. Though anyway, this should be done, and it's also my point. Transparency, which method are used, maybe which definitions, because you can use the term, appraisal assessment in different with different definitions. So now going to the next question, which conditions are necessary to build an effective citizen involvement in HTA? Well, actually, we need the interest of citizens for the common good. We need participation. Well, now less and less interest in participation. Yeah, we are a more individualist approach to the society and also to healthcare. Well, the role of patients, patient consumer, and patient organization. Well, they all may be important in some countries where they are well developed. In the UK, for instance, they play an important role in the healthcare sector. Well, less so in Switzerland. Well, we have examples. I mean, if you look at AIDS activists, I mean, they were able to modify the access to drug, to modify the research, to participate to congresses, to give their voice, actually. There is a recent case of the people with rare disease in Switzerland. I mean, a small group of people, but they assembled and made their voice heard. I mean, somewhere say, well, look, if you count all people with rare disease together, we are not so few, and we are not taken care so well enough. Well, but it's more, you know, the exception than the rule is participation, and patient associations, they are more on the defense of patients in litigations against the healthcare system and in the hospital. The consumer associations are more focused on cost, you know, reducing cost, maybe for you can buy more with the same, more healthcare with the same. So it's difficult to involve citizens. Well, yes, technology assessment Switzerland has done with panel of citizens to look at technologies, new technologies, not only in the healthcare system, but broadly. Well, yet a small group of individuals. And also there is this indirect involvement of patients. Sorry, it's the last point, I'm just switching the slide. Well, it's, you know, surveys and things like that, it's really indirect. So the last the last question about the establishment of the institutional voice. Well, we have, it was already said, we have global evidence that can be transferred from countries to countries. Well, the decisions still should be local. So we have the health technology assessment that are made internationally. Well, the feasibility, the acceptability, it's really local. And for the point of the organization of the society, of the organization of the healthcare system, well, we have access to highly specialized techniques. It's more and more concentrated, as was said by Dr. Suter, to a few centers. Well, less, I think the patients, well, they will prefer to have treatment close to their home in their own language. Well, it's not from them that the most opposition came, and you can ask Professor Suter about that. Well, mostly the difference, Mooney is calling for the voice of community, but most decisions are made at the individual level. You know, you adapt guidelines, you use guidelines with the patients, maybe use shared decision making techniques at the patient level. So my final word will be that yes, it will be possible, it will be good to have a proactive voice from citizens and communities. However, it's difficult, they don't develop easily, spontaneously, so maybe we should think about possibility to promote this institution of vote. And I will end this for the sake of time. Thank you.
My name is Elvira, I'm from Kyrgyzstan, and I'm working for a Swiss Cooperation Office, and my understanding for the HTAs, whether it's needed, is, for me, I think it's absolutely necessary in development agenda in the countries in transition, because exactly the approach in these countries is to move towards the preventive agenda from the care agenda, because within the limited resources we have to use it cost effectively, transparently, and so on. But my question would be a bit provocative. Why the HTA is needed in developed countries? It seems for me that there are several stakeholders for the HTAs, is like hospitals, patients, industries in health technologies, politicians, and scientific society. If to look at these five, I find that the hospitals, patients, and industries are not that much interested in HTAs because they don't want to reduce the cost. Because even the patients want always demand the kind of complicated high-tech treatments. They don't want to be treated against the flu just with the vitamin C and simple tablets. They want to have the antiviral medicines injected and so on. And if to look at the politicians, of course they do, because they need to have all these governance principles following the cost effectiveness, aiming at cost effectiveness and efficacy. But I think that it is more in developed countries is the HTA is really an interest for the scientific society, because it keeps them working every time. So it is just a question now, what is the real reason that these developed countries started to do these HTAs, and for whom in the end?
I may start. I mean, I think we need HTA evaluation everywhere. You know, the pace of development of new technology is fantastic, and even in developed countries, we cannot afford to pay for everything. I come from a rich university hospital, and we have a technology assessment process. For every new technology that's introduced, the department, the service, they have to comply with this, to say, well, what is new, how will it cost, can we afford this, do we have enough patients? So that, and the medical director who is in charge of this say, well, yes, if you can on your budget, and if you replace another technology with the new one, you can do that. So I think that, you know, HTA is for everywhere.
I'd like to add, you're completely right that money, for instance, in Switzerland is not a problem. Except in Lausanne, there's a look at the money.
That's why we have a good budget in our hospital.
No, it's quality. I mean, you have to look what the patient gets of it and what the complication rate is with new technology or with old technology, and to assess it regularly. And there is a lot to do in developed countries, certainly in Switzerland.
I think that was a wonderful question. I really like it. That sometimes, I mean, we do HTA and economic evaluations, and sometimes I ask myself also this question: why are we doing it? And try to be reflexive. At the moment, it seems to be the case, at least in this country, that we seem to be able to afford everything. But this might change. Even in the richer part of the world, you know, aging societies, more technological possibilities. I think now, after the financial crisis, countries like Southern Spain, Italy, and maybe even the United Kingdom, they have set priorities. They cannot afford everything, and we are better ready for the future once this changes here as well. A second point might be this country, and this might sound a bit cynical, is that we have to protect patients from getting too much. And this probably comes back to your point, quality. You know, the financial incentives in this country are so that the more you use technologies, the more you get paid. So there is, for everyone, there's an incentive for overuse. You know, we have fee-for-service, even public hospitals. They try to boost turnover. I sit on the board of a public hospital. Every 3 months we look at the figures and we say, oh, we're 0.5% behind the budget. You know, everyone is a bit sad. You know. So it could be helpful for this point.
One thing we cannot forget, we are a rich country, but we do not have enough specialists in medicine, in nursing sciences, and all these supporting, and we have to import more and more of these health professionals, and this cannot go on forever. So the means may not be limited in terms of finances with France, but in terms of good personnel.
Good morning, my name is Miriam. I'm a student in Switzerland. My question is addressed to countries, for example Mexico, where public tenders are, the decision for public tenders are taken on a national level. So the question from my side is, the basis for HTA normally is done or is by a specific device, for example. So there are many times very similar devices which may differ by manufacturing characteristics, which do not appear in the HTA description, that's how I understand it, and can finally lead to very different long-term clinical results, but have the opportunity to take advantage of an approved HTA. So my question is, in those countries, as the middle-income countries like Mexico, the decision makers of public tenders focus or trust on HTA results. Even the final long-term results of the clinical perspective will differ extremely. So what should be the role of HTA, or the relation between HTA and public tenders? That's my question.
Thank you. Just a very quick question. Just responding to things that Peter and Urs said. Peter just said that in Switzerland we don't have enough medical specialists, enough nurses. Urs was saying that there's a problem of over-provision, over-treatment. I wonder whether HTA here might follow the line that NICE have taken to include public health. Because actually HTA looking at prevention might help to deal with some of those problems.
My point about that they are underused also has been emphasized in a recent article by Harvey Feinberg in a recent paper in the JAMA, saying that there was effective. But I totally agree that we should evaluate them properly in HTA. But it's again the same thing in Switzerland. There are not so many people that will push this public health intervention at the HTA level. So they are more coming from other bodies, from other sources of intervention in the healthcare system. So we, as you have mentioned, it's a very complex system. So there are many possibilities to finance this public health intervention.
We seem to have a problem with the link of the public tender to the question. I try to answer the part that I understood. And I think there is a difference between pharmaceuticals and non-pharmaceuticals, like devices. Also in this country, we have two totally separate processes. And pharmaceuticals are evaluated sort of product by product, molecule by molecule, case by case, and then you get an evaluation for that. Whereas the medical devices, you normally evaluate in classes, which is a problem by itself. Then you have slightly different technologies, and they might change over time. And this comes back probably to the point I mentioned before, that you cannot do like one HTA at a certain point in time and then forget about the thing. So it's probably, or not probably, it is important to re-evaluate it, to probably constantly evaluate it, to have registries, like HIP registries, and to see which product performs better than the other one. With the public tenders, I try to give one point to that. I mean, if a country does public tenders, there could be a problem of too much influence on the market. For instance, we discussed that in recently. There's a problem in Germany where they do public tenders for generic drugs. And then you have probably 10 different drugs, and then they compete, and only the 2 or 3 companies that have the lowest prices get the deal, and they give discounts of up to 90%, and then the prices are probably not sustainable to run the business for a long time. So I would have to look into the Mexican case and how they do it to see whether it's an efficient case. Maybe you can answer that.
I would like to add something to the question of Martin. Now, just to explain, in Switzerland we have a problem with the awareness of the role of public health. Our federal parliament was not able to draw, but not to accept a national law on prevention. We are still lacking a legal framework for prevention in Switzerland. In a few weeks we will have a popular vote on a law on epidemics. And there is a high risk that this law will not be accepted by the people. So, of course, we are a very affluent country with very good socioeconomic conditions, and people have difficulties in realize the role and the importance of public health. And this is really, that of course, if you don't understand the role of public health, it becomes very difficult to claim that you have HTA done on public health issues. That's a great problem in our country, and this is also one of the missions of the Swiss School of Public Health, to strengthen the awareness about public health.
I fully agree with that, and if the politicians cannot really act in the right way, the popular vote, that's what I call the large democracy, to vote on everything, will not solve this problem. And that's why also I said that the complete bottom-up approach is in some of these areas it's just not the best approach. And in England, certainly in other countries, also in Holland, the approach is much more mixed, and the top-down component is I think, better than it is in our country. Now for the Mexican or in general problem of different things coming with a public tender, the problem is always what do we define if you open a new catheter, a new artificial heart or whatever, or artificial heart in general. And this is a very good question because as you said in the drug example, you should really have enough insight at this moment into different possibilities, complication, and at the beginning you do normally not have that. One device looks cheap and good and nice, has a nice color, but it was not examined against another one who maybe is a little bit more expensive but has less complication. This is a big problem also in our country. New things come very easily on the market, and then the HTA is done not at all, but it's sort of natural selection because the color of the catheter or whatever doesn't please to everybody. And I don't know how we could, in Switzerland, above the price possibility, look at these things better.
Well, we should have better means within the collected data, yet not, increasing the burden of the people who have to give this data. So it's a difficult balance to find, but we need this within the collected data to help the evaluation, the continuous evaluation of the devices, the changes, and also possibly to help us evaluate the appropriateness of the indications.
And I will be following with a lot of interest how you will move ahead with a strategy for HTA in your country. I have a specific question. As far as understood, when we heard about this coverage with evidence development, that there actually need to be somebody who is questioning, sort of explicitly questioning whether something should be reimbursed or not. Do you think it would be possible to change this to sort of having a broader approach? The reason why I'm saying that is that, very often HTA is considered to be associated with cost containment, and it can very well be. But actually, it is just recognizing, as was also said from you, that resources are always limited. But there's actually another much more progressive aspect of HTA, which is facilitating the real innovations, the real things that make changes, and have them to go much more efficiently into the system and, so to speak, killing the old practices that are not so efficient and not so effective. So do you think you could have a public debate in this country that actually could go in that direction? Would the professionals be interested in this, for example? The medical and other health professions, the politicians, insurers?
The thing is, it's very transparent. We don't know who actually challenges one of these technologies. What I know is that sort of everyone can go to the public office, to the Office of Public Health in Switzerland, and question one of the technologies, and then the office filters it through to the commission that then takes a decision. Before they do that, they go to the medical association and they go to the insurer association behind closed doors and ask them if they think it is controversial, and if they both say yes it is, then they or one of them, then they consider it as controversial. But I think it's very intransparent, and it should be a more open debate and more transparent how topics are selected. The one of us who probably would know the most about this process would be Burnand, because he sits on that commission that then has to do the appraisal, but probably not even he knows how the Federal Office of Public Health does it.
It's not fully transparent to us, and also, I have being in this commission, I cannot tell you everything that is discussed in this commission. Also my duty But even it's not, it's not fully transparent. Well, you can imagine, of course, that if something is controversial, the insurers will have a voice and say, well, are we going to pay for this if it's, if it's more cost for uncertain benefits?
If I can add just a very nice expression, the real innovation. Because in Switzerland, overall, the pharma and other technology firms always speak about innovation. But the real, they don't like too much, because we all know that innovation is something new. Yes, a patient asks a new thing, and other people too. And I think it would be very good to introduce this real innovation thing, or each innovation as an HTA after a certain period, a short period, to really look if it is a real innovation. The Commission looks at that naturally and grades it, but it's overall for me striking that all things are not evaluated again after a certain time to really look if they are still the standard best treatment. Again, has not to be the cheapest, but the best. And this must be done, as you say, on a much broader way.
A solid, well-constructed appropriateness study, population-based appropriateness study for key procedures that could be assessed broadly within the Swiss system so that we can have some evidence, not unlike what Elizabeth Meglin has done I think a decade ago in the States, and change the conversation on overuse, misuse, and underuse. Not to forget that underuse is a key issue in our business. So, would it be a way to approach it in your context?
I would say yes, it should be. We have conducted but very limited studies of the appropriateness of care, overuse and underuse in certain sectors, but we don't have a big picture of all intervention and the appropriateness, overuse, underuse globally. And then we really, it will be an important study to have, not only in Switzerland but in globally.
Very good idea. I see some problems in Switzerland to have this list really accepted and adopted by the stakeholders, because this list, I think, in a popular vote afterwards or in a vote of the stakeholders, will not go through for many items which we could consider very important because the interests of the stakeholders are so different.
I totally agree with your suggestion. I think that to improve effectiveness and efficiency of the healthcare system, we need to look at this second part of translation. That would be a good example. Unfortunately, there is no industry behind this kind of question, and so the funding might be the problem. It's key, but so that's why I said we need political will to actually do that and probably allocate some public resources, which might be a good investment in the long term, because if the figures are right, and even our politicians now say that 20% of our budget is waste. So if we can discover some of that waste, we could do quite expensive studies.